Good evening, everyone, and thank you for joining us. My name is Samantha Holloway. I'm a council member of the European Wound Management Association, chair of the EWMA Education Committee and Teacher Network, and I'm a reader based in the School of Medicine at Cardiff University in Wales. Today's webinar focuses on the topic of telemedicine in wound management, current practice and future potential. Due to COVID-19, it has become more challenging to deliver wound care to chronic wound patients, and telemedicine has become an increasingly important tool that can help healthcare professionals continue to provide care, prevent exposure to COVID-19, and minimise the risk for further complications related to the chronic condition. This webinar will be recorded, so you'll be able to watch the video recording on demand. The recording should be available on the EWMA website within the next few days. You can request a certificate of attendance for both the live participation in the webinar and via the on-demand version via the EWMA website. I'm very pleased to welcome the speakers for today's webinar. EWMA Council member Luc Teot. He's the head of Department of Plastic Surgery, Burns and Wound Healing at Montpellier University in France. And Luc will be sharing the French experience with implementing telemedicine in wound care and discusses some of the challenges and solutions in detail. I'm also delighted to welcome our current EWMA president, Alberto Piaggesi, who is the professor and director of the Diabetic Foot section of the Pisa University Hospital in Italy. And Alberto will be presenting on the Italian experience of using telemedicine, as well as future potentials. Each speaker will speak for 15 minutes, and there'll also be 15 minutes at the end of the webinar to ask questions. Please type your question in English if possible in the question box, which is to the panel on your right. I would ask that you type your questions as soon as you have one and include the country you are based in, so that the speakers can provide context-specific responses. The speakers will aim to answer as many questions as possible during the final 15 minutes, and any questions that have not been able to be answered during the session will be responded to via the EWMA website. I'd now like to invite our first speaker, Luc Teot. Thank you, Luc.
Thank you, Samantha. Dear colleagues, I will propose to you to discuss about the general act of telemedicine and speaking more about the French experience on the telemedicine during the COVID and the post-COVID period in wound healing. So globally, telemedicine exists for a long period of time, 2 decades. Different modes of telemedicine are now well defined. The teleconsultation, the patient is present, is at distance, and there is more or less, depending on the availability and the reimbursement system, there could be a caregiver close to the patient. This is one of the best options concerning wound care. What we call tele-expertise is just an exchange of informations between professionals. The patient is not there, is just asking questions to somebody else you know, you trust, and you would like to have his advice. Other options like telesurveys, like in cardiology, for instance, where data are coming automatically at regular intervals from an implanted MD to somebody who collects the information and make decisions depending on the information he gets. Each European country, as usual, I would say, has developed his or her own regulations. So it's not easy to generalize a practice from one country to the other. Each European country will define the reimbursement rate, if any. We are lucky in our country, and we started some years ago to have the telemedicine in wound care reimbursed. And I will tell you why and how. Key elements for improving practices in tele-wound care. You need to have a visio of high quality. You have on the market largely diffused public solutions, which are free of charge, like WhatsApp, Starleaf, FaceTime. You can use them if you just do visio. You have some paying solutions which offer more than just a visio, you can profit of these solutions to exchange, but more or less it's not completely securized. The message is that there is no need for a specific transmission security during Visio, because what we are doing now is not hackable. You cannot hack it during the Visio time, and it's an important information. The presence of, during the teleconsultation, of a non-expert person who is in contact with the patient, a nurse, a relative, other, may remove the dressing, may act on demand, may be guided by you as an expert, but you should be an expert. The telephysician at distance or a delegated nurse, an expert nurse, should be an expert in wound healing. This is very important, and this model has proven that it changes a lot concerning the global results of telemedicine in wound care. And you have, if you need to have a security in the data transmission via a platform, you have many possibilities to exchange pictures, reports, X-rays, biological data, etc. But as far as you transmit, you should use a secure system. The primo teleconsultation is something which is important, because your attractivity as an expert makes people coming to you and asking for a consultation. And when they cannot come because of the COVID, if you are not allowed to do a primo teleconsultation, that will be a problem. So in some countries, the first visit can be realized and is covered by the insurance system in teleconsultation, like France, Italy, some others. You have some prerequisite to do this primo teleconsultation. You can ask questions to the patient or his surrounding people with using a chatbot, a kind of robot, which makes a decision tree. And this is a little bit sophisticated when you start, but it's very useful when you use it. You have a centralized team, which is formed by a secretariat who collect administrative informations, and a specialized coordinator, a nurse, collecting medical history reports from the primary care team, GP or nurse. The patient or the people around the patient will have to download an app, which can be Starleaf, Skype, Zoom, Teams, whatever, and you have to test the connection. So to be clear, your secretary has something to do to prepare the primo teleconsultation. During the connection, the primary care nurse or an assistant in contact with the patient will explain the situation, clinical situation, to the expert, remove the dressing, take picture, assess the wound under the guidance of the expert, exploring depths, very important. So the expert at a distance will guide the nurse and say, could you come into, what is the distance inside? Is there an undermining, etc. And the experts will fill a wound database and incorporate the pictures coming from the nurse and send, which are sent electronically, and then they will send electronically a proposal of care at the end of the teleconsultation. The next one is the follow-up teleconsultation. You know the patient and you want to check up if everything is going well. This one is reimbursed in many countries. It's a date for the teleconsultation is fixed by the secretary, depending on when the primary care nurse may come at home. So you have to discuss with the primary care nurse, and she will change the dressing and participate to the Telemedicine Act. In some countries, this act is reimbursed, is paid for. This is the same procedure than before, and it's again, a real exploration of the wound, which is guided by the at distance wound expert and realized by the primary care nurse, and you work as a team. Can you do that? Can you do that? Could you press this part? Is it painful? Is it inflammatory? Does it hurt, etc. And you get on your database successive pictures. So you have a specific wound database software which allows the expert to compare, analyze the wound evolution, and decide which local or systemic treatment is the most appropriate. What are the limitations of this teleconsultation? You have organizational needs. Means you need to have a primary care nurse present at home during the teleconsultation. So you need to organize agendas. The nurse should use his GSM and an already download app. Some nurses will not accept that. Some regulations will prevent that also. In some countries, teleconsultation is not by itself. It's a decision of the GP or the doctor who coordinates. So here again, there are different rules in different countries. A wound expert should be accessible at the same time than the primary care nurse. Again, problem of agenda. You need an organizing secretariat, an agenda, a tele agenda, because you have rooms and you use them like your rooms in physical presence. Means you have a virtual room and you feel the agenda of this room. And you have, in some countries again, you should have an agreement from the patient or the surrounding people for doing telemedicine. Because patients may feel a little bit, not comfortable with telemedicine. You should explain them that only the doctor will see what is exposed, will see the house, will see. So there are concerns about the patient, and this is why we need an agreement for the patient, of the patient. The second limitation is connectivity. Depending on the countries, you have 3G, 4G, 5G, and sometimes we use the web of the patient, but this needs to have a connectivity at least. And the third one is reimbursement. In France, the nursing time at home for telemedicine is called telecare. It's applicable to other paramedics, but it's reimbursed. The expert physician in wound healing is reimbursed. The delegated nurse, expert nurse, a physician can delegate to an expert nurse, a kind of tissue viability nurse, I would say, with different practices, different validation systems by the universities and by the deciders. So you can delegate to a nurse the teleconsultation. In Italy, 2 weeks ago, the Primo Teleclinic was reimbursed for the doctor and the nurse, which makes Italy one of the first European countries to reimburse this Primo Teleclinic. The second act is, I told you, tele-expertise. It's an exchange of documents. You use a securized message system. A non-expert asks an expert using text, pictures, phone calls. No need for the presence of the patient. It's used for decades in daily practice, infection disease call system, post-surgery, complex situation, etc. Transmission should be securized, of course. You cannot use WhatsApp. Why? Because WhatsApp, it's an exchange between two phones, and you know the numbers. So if you have a clinic with you, or if you call regularly a psychiatrist, and it's easy to demonstrate that you need a psychiatrist because you call him on WhatsApp two times a week, for instance. And you have specific software. In France, we have 150 softwares. So you choose the most accessible or the most consensual for your practice, which is in your country. The limitation of the tele-expertise is technical. You don't see the patient. You don't see the wound. You have no access to the home by Visio. This is very important. This is important to check the surrounding hygienic conditions. And the wound depths cannot be analyzed. And all informations are coming from a non-expert. I ask you, you are an expert, but my words are not the one that the expert is expecting. So you have a risk of underestimation of the gravity. And it's preferred for a follow-up of a clinical situation which is already known. Reimbursement, in France, it's reimbursed with limits, no more than 3 successive tele-expertise patients. And in other countries, I don't know, maybe you know, but I think it's something you have to explore. So if we build a kind of, schematic approach, respective indication of the act of telemedicine for evaluation and follow-up at distance of a chronic complex wound, teleconsultation is mandatory for establishing the healing prognosis. You see on the left, the hygienic condition sometimes. You see in the middle, somebody, the camera was anticipated a little bit, and he was smoking his cigarette. And when the doctor said, you smoke? He said, no. And on the right, you see how to explore the depths of the wound and the exploration is done by the non-expert who is in contact with the patient. So you can delegate, and depending on what you delegate, you can delegate a BPI, you can delegate debridement also, and you control the movement. You say no, yes, go deeper, etc. Tele-expertise are more limited indications. You can use as a triage at the beginning, should be followed by a presential consultation or a teleconsultation. You can use it in the post-op evolution. You cannot assess the depths, and our recommendation from the Ministry of Health is stop WhatsApp. It's not secure for transmission, and you risk some medical legal problems. What experience tells us? In France, in our team, we realized 24,000 teleconsultations since 2012. We were under a French national health project. Some comments. The patient is more than happy to see the doctor, even on a small screen. The patient has the impression that the doctor is finally coming back home and sees the interior of the houses again. Remember the house of Hippocrates. You are a doctor. You swear on the Hippocrates oath, and you say, my eyes will hide what I see in the houses. But if you don't see anything in the house because of tele-expertise, you're not respecting the house of Hippocrates. This act is safe. There is no risk for the patient, especially if the paramedic is present. COVID imposes to change minds. The physical contact between the caregiver and the patient is not anymore the fundamental principle of a good medical act, and if even worse, if it becomes risky for the patients to come at the doctor's clinic. Now we are in a position where necessity should make law, so your law has to be adapted to this necessity. You should not stay on principles, because if not, and we see that, the patient during the COVID period is abandoned or poorly managed because you take care of COVID and you don't take care of the patients presenting wounds. And if you transform your visits into phone calls, you don't show the wound reality. So, the difficulty to change is really proportional to the need you have to change. We worked on network. This network was published some years ago, 4 years ago, in plastic and reconstructive surgery. And it's good because you have all the contacts. We have the nurses, we have expert nurses, and we have expert doctors. And we take care about 1,500 patients per year, more or less. And the objective is to assess the wounds wherever the patient lives, in remote areas, in very popular areas, close to the Mediterranean Sea, far in the mountains. So the objective is to give to anybody the same chances. We have a software. This software is old now, but you see that you can check the evolution of the wound, and it's something that which can be used with or without telemedicine, of course. But this is certainly a key of the possibility afterwards to come back to your decision and see what's going on. We function as a central call center. We have a central call center which is now extending for 6 million of people. We started with one number. The requiring nurse will ask the call center saying, I have a problem with a wound, and then it will dispatch, the call center will make the triage and will dispatch on the right expert who is living close to the patient. And whatever it be, vascular, endocrinology, diabetic, geriatric, you will have an expert which is adapted to the question. And you use the smartphone of the nurse or the patient website. It's called Montpellier. Before the teleconsultation, we have some secretariat working and coordination working. So 2 actors, one is the secretary, another one is a nurse that will triage and make the situation more clear in order to define what is the real problem. It's like in Georgetown Hospital in Washington. You ask directly one person who is a nurse and who say, yes, this is what you should have as an examination, and he will give the a date for the first primo teleconsultation. This primo teleconsultation, the recurrent connects with his app using a securized number. The expert send an invitation to be present on the visio. We have two screens. On one screen we have the patient, and on the other one we have the software. And we work together with the local nurse to have pictures transferred, to have informations on the treatment, and at the end, a protocol of local care is sent to the GP and the nurse using an electronic system. After the teleconsultation, the coordination team will articulate the wound management and other pathologies together with the caregivers. And these specialists and the local technical plateau are accessible around the patient home. We need a technical assistance. Sometimes with such a big number of patients, we need technical assistance because the nurse is a little bit feared of pressing the wrong button. Somebody is there to be really smooth the connection and the different steps which have to be followed by the nurse and by the doctor. So this is some use of different actors.
Luke, sorry,
yes.
I'm going to have to move you on in a little minute. You've had about over your 15 minutes. So
I will, yes. So Dave, this is my last paper on there is no difference between the groups on complete wound healing if you use strict telemedicine or physical presence at the clinics. So I will close with that. We have written a book in French with all different initiatives in telemedicine, because there is a lot of possibilities. Coordination at home is becoming the big word. Means having a patient and knowing what's around the patient in terms of wound care. I will finish that and wait for your questions after the talk of the next.
Yes, thank you so much, Luke. And I was sorry to have to cut you off a little bit there, but I do need to let Alberto speak as well. And I'd just like to remind the participants that there are opportunities to ask questions, and you do that by pressing or putting your question into the question panel, which you should find to the right of the screen. So I'd encourage you perhaps to do that while Alberto's speaking. So thank you, Alberto, and over to you.
Thank you very much for inviting me speaking in this interesting webinar. And I will, let's say, see things from another point of view to give you some different approach to telemedicine, which is being used and adopted in wound healing since a long time, actually. And talking of diabetic foot, which is my field of expertise, I will okay. I will start with this paper, since in 2007, which commented how diabetic foot ulcer could be managed at home more than 10 years ago by the same approach that Luke Teot described just a few minutes ago. Doctors were in contact with the patient with the help of a caregiver or a professional at home at the patient, and this was proved to be safe, at least, and effective in treating patients. Same approaches were shared by others. In France, there was an experience in which not only diabetic foot were examined in diabetic patients, but all the complications by visiting the patient with the truck, equipped to screen for all the complications of diabetes, and to the internet being in contact with the different experts for giving them solutions to the problem. A sort of moving clinic that would be supplied and supported with the expertise from the hospitals. and this is something that also led to technical improvements. Systems were developed to focus on the ulceration and give enough information on the ulceration when addressed and visited in this remote situation. This is a system developed in UK, in which not only the photograph that you can see on the right, but also the planimetry that you can see in the middle, and the temperature of the area could be recorded and transmitted by means of this system in the teleconsultation and televisit. So a sort of interest 10 years ago on telemedicine developed, and also it could be tested versus traditional visits, and it was proved that it was at least as effective as the standard approach in terms of healing, but also in terms of, as another randomized controlled trial proved, in terms of major amputation, in terms of sparing a major amputation. So it was not only possible, but it was also effective. So something that would be interesting from a general point of view if it was also competitive in terms of cost effectiveness. And this also was proved from these authors more recently. But after a long time of observation in a real population in Denmark, it was proved that televisits on average would lead to an incremental effect and a decremental cost. So it was on the right side of being cost effective. From that approach to focus on ulceration, more recently, new approaches were developed. This is something that is in the nature of remote monitoring of people. It's not only related to diabetes and diabetic food, but this was also tested on diabetic food. Not only the ulceration, but in this case, the gait, the way people was walking and the number of steps and so on, information on how patient would behave before and eventually after having get an ulceration, in order to prevent or secondary prevent the ulceration to come in the patient. And we also had an experience in this with a novel approach. New sensors were developed to be put inside the shoes, in this case, what they call the wearable technology, and in which we could be able, in assessing temperature and oxygen delivered to the tissues. And this is something that, again, put information in the system, not only in the acute phase, not only when the ulcer was present, but also in the period before and after, and the developing of the ulcer. This was a project endorsed by EWMA, and it was a Swan Eye Care project that, through the internet, again, information on the condition of the patient, not only of the lesion, was transmitted, and it was a sort of telemonitoring of the patient condition. And this is something that at the end came at the commercial level, and nowadays these new devices have been commercialized by companies. This is an Italian company that developed a device that coupled with this offloading cast, floating boots, is able to register and communicate not only to the doctor, but also to the patients, the real level of risk that the patient is putting himself in the condition he is behaving. And it's something that is interesting, because not only is something that connects the patient, the doctors, and the risk, but also because it has been recognized as being reimbursed for the health system and the insurance system in the US, giving a new, I would say, drive for doctors and specialists to empower the patient with this protection, with this important protection. And these are the codes that have been attributed to these remote monitoring systems in the United States. So we observe a sort of development from telemedicine focusing on ulceration, then moving to the risk of ulceration and the general situation of the patient, the general condition of the patient. A sort of evolution towards primary and secondary prevention, not only on monitoring of acute condition. So if this is such a long story and such a successful story, why this has not been so implemented in real life? One of the aspects, like this paper is focusing on, is that still there are technical aspects that should be solved. This paper, published in 2017, on different way of picturing ulcers, for instance, demonstrated that there are still problems. This is the likelihood ratio of being in line with the traditional consultation. So this way, we studied point that the way that telemonitoring and televisits with this approach is still not paralleling the level, the quality of is below these lines, not qualitatively paralleling the traditional visits, both in terms of detected clinical characteristic and also, more important, in the way the treatment decisions are made. But probably this is something that, as Teot said, will be overcome with the upgrade of technology, access of the internet, upgrade of the patients, and availability of resources. This is something that probably will be covered, will be resolved in due times. But what is probably more important is that a political gap is still existing in adopting this situation, because it takes to reorganize the system around telemedicine. Like I said before, when you change from a technology to another, like from gas lights to electric lights, there is a resistance at the beginning. And this is something that COVID emergency, in a way, prompted. Because in this situation in Italy, with the necessity of maintaining social distancing, with these dramatic figures on the scene, we were able in few weeks, really few weeks, of having a law in Tuscany, but also in other regions, in which, sorry for the Italian, but the lines, the guidelines on telemedicine has been promoted and realized. Now, in few weeks, because of COVID, we synthesize years of debate, years of decision-making on telemedicine. And now we are having the full picture of televisits, which are, as Luc Teot said before, real visits with the patients involved, managed by specialists. We don't need, in Italy, GPs for prescribing televisits. And that can be done more or less in the same way that you have heard before. And that leads to outcomes that are clearly described, and that may influence and condition the follow-up of the patient. We have also teleconsultation, which is what in France they call tele-expertise, in which GPs are on the control, and they can prescribe, they can request a reservation of teleconsultation to specialized clinic, and the video conference, mail or telephone could be used for this without the involvement of the patient, and still the patient has to be managed by the GPs. These are not reimbursed, but televisits are reimbursed. So this is something that in a model like this one, which is more or less the way that the majority of diabetic food clinics in Italy are organized, in which there are emergency, but also normal procedure program activity that are being made, may lead in a situation like in this emergency that we are living now, in which only the emergency are managed traditionally, and all the other activity can be, in a way, managed on remotes, on tele consultation and televisits. This is one of our doctors doing the job, but what we have experienced in these days is that in 55 days we follow with consultation televisits almost 260 patients, and this have led to the urgent management of 36 urgent cases in operating room and hospitalization and so on. So this is something that in no time almost took place and put us in the condition of give answers to real patients in real difficulties at home. And this was not the only experience. In the United States, in the same moments in which in Europe we were implementing in a fast way televisits for our patient in the US, podiatrists called for a sort of rationalization of telemedicine, and they gave the rules and the stratification of patients according to the possibility of managing them on telemedicine fashion. So it's something that it's interesting all of the countries involved in COVID. I would conclude making some reflection. I think that COVID, yes, was a primer for telemedicine adoption and implementation, but and that chronic wounds and diabetic foot in particular are typically good example for applying this approach. And they're a good example because of the characteristic of the pathology, but also because of the chronicity of the patient that put the needs of frequent consultation, frequent visits. And that the telemedicine is a part of a more complex, a wider scenario, which can be defined e-health. You have heard about telemonitoring, you have heard about wearables. Well, I think that this, together with artificial intelligence and big data mining, will shape the future of these chronic pathologies in a few years, and we will see more in the next tutorial about this. And I would say they are here to stay. It's not something that will end with COVID, because you've seen it's effective, it's cost effective, and solves a lot of problems in a very difficult to manage patient like the one with chronic wounds. And we all need to upgrade on that. This is my personal opinion, but also the opinion of EWMA, which is, and I am talking in this moment as the president of EWMA. EWMA is strongly supporting this movement, and I have to say that has focused and promoted an initiative on telemedicine, whose leader is Teot, because of his huge experience, long-lasting experience in the field. And EWMA, through this initiative, is willing to support and to look after all the specialists and patients that will profit, I would say, of the benefits of this new technology. Thank you for your attention, and bye-bye from Pisa, which is finally passing through the phase 2 and start again to live out in the streets. Thank you.
Thank you very much, Alberto. So we do have a couple of questions which I'll move to from the participants. The first question from Beta is for Luke Teot, who thanks you for your great presentation and just asks whether the book you presented, the textbook, is available in English too. So you mentioned a book at the end of your presentation.
The book is not yet available in English, but with Google Translate, you can have a translation very quick in English. We are thinking with Alberto to have a rehearsal of the book, which was published 5 years ago, something like that, with EWMA, and that will cover many of these practical aspects. We are also planning, but depending on your willing to receive the more detailed messages, some more webinars on this topic, specifically focusing on either teleconsultation or tele-expertise, or how to make monitoring at home, or well, all these aspects are building the wound healing 2.0. Really, I appreciate what Alberto just said, which is the beginning of a new era where patients will not have to come for 300 kilometers to see the expert, and be in quick communication with an expert, and I think it will change.
Okay, thank you, Luke. Next question probably is for both of you. You both talked about different ways that you can provide telemedicine, and you talked about the technicalities and the software. So specifically, what application program do you use for telemedicine in your practice, Luke?
Well, the application program is, I told you, we are moving fast, because we had an application and the software which was called Infinis, and which was grouping the software and the mode of communication on the same platform. Now we are thinking about having separating the two. One is the file concerning the wound evolution and all the messages, pictures, X-rays, reports coming on this file, and here we need a securized software. And the other one, which is communication and visio, and the message is use any type of visio you want, as far as it's linking, not phoning, linking yourself with the patient or with the nurse close to the patient. And we are remodeling all this stuff, because this is really the passing band is should be as high as possible if you want to have a good visio and a good evaluation of your wound. So this can be done with very the most popular softwares are very useful in terms of visio. If you use something like FaceTime, you can have very good information, but as far as you transmit something, you should use secure systems.
Okay, thank you, Luke. And the same question for you, Alberto. What's the name of the application program that you're using for telemedicine?
Yeah, I can talk for Tuscany, because as you know, in Italy, the organization of healthcare is responsibility of the regions, not of the states. And in Tuscany, we have a proprietary system which is based in the web server of the health authority, which is called B-Mode, and it is a platform that make it possible to be in contact with the patient that have to download a specific app for that. But in this emergency situation, we were allowed to use this platform together with any system that the patient may have at his own availability, in order to, I would say, cope with an urgent situation. So depending really on the situation on the patient side. Really.
Yeah, so it can be quite responsive, which is good. The next question is, how could we train general physicians in remote areas to treat diabetic foot ulcers in this COVID scenario with telemedicine? I guess that's a question for you, Alberto.
This is an interesting question, because, you know, depending on the level of complexity and depending on I would say the level of skills that the general practitioner, for instance, gets as a basic preparation, we can imagine different scenarios. As you know, diabetic foot is a complex pathology, may present in easy situation, but even in very complex ones and very emergent ones. The important and innovative aspects of telemedicine, from my point of view, is to being able to give in timely the best treatment to the single patient according to the severity of the pathology. If the caregiver or the health professional or the general practitioner is at home with the patient and discuss with the experts the case, then it will be the time in which we together can decide if the patient can be managed at home, should be transferred in a peripheral hospital, or should be immediately sent to the reference centers. And this is something that nowadays it's a critical aspect of managing diabetic foot, which is the delayed referral of the patient. Telemedicine could be an option, could be a tool to overcome this gap, this difficulty.
Okay, thank you. And it's another question for you, Alberto. Is there any app or device on the market to measure ulcers and wounds?
There are a number. There are really very many. If you go on App Store on your mobile, you will find a number of them, both commercial and no profit. This is something that is for diabetic foot not the only key, because measuring the ulcer is important, but this should be done in a context of the evaluation of the clinical situation of the patient, because the same size of an ulcer may be related to very different clinical situation. So I would say that this would be inserted in a, I would say, more integrated approach.
Okay, thank you. Luke, perhaps you could take this next question. It's about managing telemedicine systems and making sure they comply with data protection, so GDPR and MDR regulations, and how do you ensure that?
Yeah, this is a very good question, because you have a lot of competition on the market for the moment. Most of them in our country is authorized or not by the public deciders. It means you cannot offer any system if you are not authorized. An authorization is, I told you, mainly how to get connection. This is the first authorization. The second one is how to store the data, and this is a different companies, most of the time specialized companies, who are allowed to store big data and to remove them after, depending on the country. In France, it's 90 days. 90 days you cannot have access to the file, except if you ask for coming back in the system. If not, your data will be completely secured, protected, and all what we RGDP rules should be respected, because this is and you have more and more regulations at the European level concerning the right of access to these data and the right of treating them, and the patient rights are growing in Europe globally, and this is good, because it's the respect of and one thing is, now in many countries in Europe, the patient has the right to decide if you, as a doctor, you are allowed to see all his medical file or not. It's a private property. The medical file is his own property, and he has to decide yes or no if he can give you access to these data.
Okay, thank you, Luc. I think we've got time for one more question, perhaps two, depending how quick we are. So there's a question, really, I guess, for both of you, is which are simple tools or devices that can be used by GPs to cope with patients with diabetic foot ulcers in this telemedicine era? So perhaps just a quick comment from the two of you about the simple tools that people can be using out there. Alberto, you want to take that first?
If you're related to tools that may help GPs in evaluating the lesion, I think that basic tools like a ruler and the probe could be the best one. But if you are talking of electronic equipments that may help patients, the general practitioner with patient, or more complicated ones, maybe the end pocket Doppler ultrasound machine and the biotensiometer are the two ones that could be helpful for the patient, for the GPs to assess the situation of patient, and on the vascular, the Doppler, and on the neurological, the biotensiometer side of the pathology.
I'd like to take this last question because I think it poses an interesting thought for everybody. Thanks, Jana Slicker, for this question. For both of you, do you think it will be practical to equip pharmacies with proper tools and programs to make that link between patients and doctors? So just to perhaps a minute each, just thinking about how it could be used in pharmacies and communities.
Yeah, I think it's a very good question. Some pharmacy in our country, this is not due to COVID, but this is due to the medical deserts we have in the north of France. The pharmacy have equipped themselves with a cabin of telemedicine, which is something very useful, because the pharmacist is becoming, again, I would say, a real actor in medicine when there is nothing else, and they do it very well. So yes, I think impacting the pharmacist in the wound care pathway is good, because he knows the dressing. He can be a good advisor. He respects, like nurses, most of them respects the protocols, and inform you when he has some difficulties, I would say. Yes, I'm in favor of involving the pharmacist in the system.
And Alberto, just the last thought from you.
On this side, well, the major resistances to this involvement of the pharmacies in the process comes from the pharmacists in Italy, which are not very, I would say, not very enthusiastic of participating in these projects. Such project, we had an experience years ago, because they are basically in Italy, I would say, commercials, not public officers. So the pharmacy in Italy are owned by private that sell drugs, basically. And so this is an issue, but in general, on theoretical basis, I am completely on the line of Luc, of involving, I would say, not only the pharmacists, but also I would say the general physician, the general practitioners, the ones that are living in small villages that are in a way more the first line of contact.
Okay, thank you. So I'd like to thank you both again for some excellent presentations, and there's a lot more to discuss. So for those participating in this webinar, there will be further activities from this. I'd like to thank you for taking part in the webinar, and thank you for your questions. Don't forget you'll be able to access the video recording of the webinar on demand via the EWMA webpage. You can go to www.ewma.org and please follow the link from what we do to the webinars area. You can also follow us on all social media platforms, including Facebook, Instagram, Twitter and LinkedIn by searching for @EWMAWound. So thank you again, stay safe and good night.
Good night.
Good night.